In this video, we shall understand the role of hepatic artery embolization for neuroendocrine tumors. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been told you need hepatic artery embolization for liver tumors, you're in the right place. I know facing a liver-directed procedure can feel overwhelming, especially when symptoms from neuroendocrine tumors have been affecting your quality of life, but today we're going to walk through exactly what to expect before, during, and after this treatment. Hepatic artery embolization is a specialized interventional radiology procedure designed to treat liver metastases. That's when cancer has spread to the liver. Think of it as cutting off the blood supply to tumor cells that live in your liver. Unlike normal liver tissue, which gets blood from two sources, tumors rely primarily on the hepatic artery. By blocking this artery with tiny particles or chemotherapy-loaded beads, we can starve the tumor while preserving healthy liver tissue. See the cartoon image to understand the concept. This matters because, for patients with neuroendocrine tumors that have spread to the liver, embolization can control symptoms in up to 75% of cases when liver function is preserved. Before we dive deeper, let's establish the three main types. Bland embolization uses particles alone, chemoembolization adds chemotherapy drugs, and radioembolization uses radioactive particles. See the representative CT of a NET metastasis. The preparation phase is absolutely critical for your safety and outcome. If you have carcinoid syndrome, that's the constellation of symptoms including flushing and diarrhea caused by hormones released by neuroendocrine tumors, you'll need special medication called Octreotide to prevent a dangerous complication called carcinoid crisis. Here's the protocol. Patients already on Octreotide continue their medication, while those new to it receive 100 to 200 micrograms 3 times daily subcutaneously for 2 weeks prior to the procedure. If your procedure is more urgent, intravenous Octreotide can be given for 1 to 2 days beforehand. This medication works by blocking the massive release of hormones that manipulation of the tumor during embolization could trigger. Your medical team will also conduct a thorough pre-procedure assessment. This includes cardiac evaluation, because patients with significant carcinoid heart disease, damage to heart valves from prolonged hormone exposure, may need valve replacement before liver procedures. Think of it this way. If your heart can't handle the stress of embolization, we need to strengthen that foundation first. Blood tests check liver function, kidney function, and blood counts. The indication must be confirmed by a multidisciplinary team that includes an interventional radiologist. On procedure day, you'll receive perioperative Octreotide prophylaxis if you have carcinoid syndrome. The intravenous infusion starts 12 hours before anesthesia at a dose of 50 to 100 micrograms per hour, titrated up to a mean dose of 100 to 200 micrograms per hour as needed. This continues throughout the procedure and postoperatively until you're clinically stable. The actual embolization is generally performed under general anesthesia. Your interventional radiologist threads a thin catheter through an artery in your groin, guiding it to the hepatic artery under X-ray guidance. Once positioned, they inject embolic material. This could be bland particles, chemotherapy drugs like streptozotocin, doxorubicin, or adriamycin mixed with embolic agents, or radioactive microspheres. Here's where it gets interesting. Because of the high morbidity risk when there is a high tumor load in the liver, treatment to separate sections can be done in separate sessions 4 to 8 weeks apart. That's about 1 to 2 months between procedures, allowing your liver to recover between treatments. The choice between bland, chemo, or radioembolization depends on your tumor type. For G1 intestinal neuroendocrine tumors, where chemotherapy offers little benefit, bland hepatic embolization is preferred. TACE or radioembolization may be reserved for G2 tumors or pancreatic neuroendocrine tumors. Recent systematic reviews of over 100 studies involving 5,000 patients show a symptomatic response in about 55% of cases, with outcomes not varying significantly by embolization type, though radioembolization showed a tendency for better symptom and tumor size response. Now you might be wondering what happens immediately after the procedure. Most patients experience what we call post-embolization syndrome, which includes pain, nausea, and fever. This is actually expected and indicates the treatment is working. It's your body's response to tumor cell death. Pain management is crucial. Non-histamine-releasing opioids like fentanyl are typically used because other pain medications could trigger hormone release in neuroendocrine tumor patients. Nausea and vomiting are common. For moderate and metagenic risk procedures, prophylaxis with anti-nausea medications and dexamethasone is recommended. Fever is part of the inflammatory response. Here's what's important. These symptoms typically peak within the first 24 to 48 hours and gradually improve over the first week. However, if fever persists beyond 72 hours, becomes severe, or is accompanied by confusion or worsening abdominal pain, this could indicate infection or liver abscess, requiring immediate medical attention. The Octreotide infusion continues postoperatively and should cease slowly over the first postoperative week rather than stop abruptly. Hypovolemia, that is, dehydration, and pain-causing sympathetic stimulation should be avoided in the postoperative period because they can trigger hormone release. Most patients stay in the hospital for observation following embolization. Typical hospitalization ranges from 1 to 3 days for bland or chemoembolization, allowing monitoring for post-embolization syndrome and ensuring adequate pain control and hydration. Recovery from anesthesia may be substantially delayed in some patients, so don't be alarmed if you feel groggy longer than expected. Regarding repeat procedures, locoregional therapies can be repeated if hepatic function is preserved. The evidence shows that hepatic transarterial embolization controls carcinoid syndrome symptoms in up to 75% of cases and can be repeated when liver function remains adequate. Sessions are typically spaced 4 to 8 weeks apart when treating different liver sections sequentially. If you're supporting someone through this, understand that the decision to repeat treatment depends on tumor response, liver function tests, and symptom control. This is what everyone wants to know. When do symptoms improve? For patients with carcinoid syndrome undergoing embolization for symptom control, improvement can begin within days to weeks. A systematic review reported symptomatic response in 55.2% of patients, though the timeline varies. Think of it like this. Immediate relief from flushing and diarrhea may occur within the first week as hormone-producing tumor bulk is reduced, but maximum benefit often takes 4 to 6 weeks as inflammation settles and your body adjusts. For patients who underwent locoregional treatment for focal liver progression, the median time to requiring new systemic therapy was 32 months. That's nearly 3 years of disease control. That's about maintaining stability without needing to change to a different treatment approach. However, radioembolization should be used with caution in patients with small intestine neuroendocrine tumors, given the risk of long-term sequelae, including liver fibrosis and cirrhosis, particularly in low-grade tumors, where life expectancy may exceed 8 years. So here's your bottom line. Let's talk about the 3 categories of action. This week before your procedure, if you have carcinoid syndrome, ensure your Octreotide prescription is filled and started as directed. That's 100 to 200 micrograms 3 times daily for 2 weeks before. Complete all pre-procedure blood work and imaging. Arrange for someone to drive you home and stay with you for 24 to 48 hours after discharge. Pack for a 2 to 3 day hospital stay with loose, comfortable clothing. Discuss with your doctor what type of embolization is recommended for my specific tumor and why. How will we manage my carcinoid syndrome symptoms during the procedure? What are the absolute contraindications I should know about? Remember, liver failure is an absolute contraindication, while portal vein thrombosis is a relative contraindication. If I need repeat procedures, what's the typical timeline between sessions? What follow-up imaging schedule should I expect? When to seek immediate help? Fever above 101 degrees Fahrenheit persisting beyond 72 hours. Severe abdominal pain, not controlled by prescribed medication. Confusion, severe dizziness, or difficulty breathing. Signs of carcinoid crisis, severe flushing, rapid heart rate, dramatic blood pressure changes. Yellowing of skin or eyes indicating possible liver dysfunction. Let me quickly recap. Hepatic artery embolization is a targeted treatment requiring careful preparation with octreotide if you have carcinoid syndrome. It involves selectively blocking blood flow to liver tumors, and it typically results in a controllable post-embolization syndrome managed during a 2 to 3 day hospitalization. Your next step, complete your pre-procedure assessment and medication protocol, as directed by your interventional radiology team. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. The European Neuroendocrine Tumor Society provides comprehensive guidance papers on liver-directed therapies, carcinoid syndrome management, and neuroendocrine tumor treatment algorithms. Full links are in the description below.